Well, thank you very, very much for the introduction. I do want to say that the work as part of the Down East Treatment Center is really a high level of collaboration. Though MHC might be the licensed entity, it's a significant partnership. And we, as a matter of fact, just provided some information for the Governor's Opiate Summit, if all how that happens, to talk a little bit about the model and how it's come together. So, but thank you for the introduction. Really appreciate it. So what wanted to do today, and I think Eric did some of this at our last gathering last month, was to talk a little bit about substance use counseling, behavioral health substance use counseling in the COVID epidemic, but also, actually last night, I was re-looking at some of the SAMHSA Tip 63 information, and it just came out this month, and some of you may have already seen it. I figured I'd do a little bit of an overview as well, and I just added it actually last night and this morning. And we'll talk about how it sort of affects some of the work that we're all doing during the opiate during the COVID crisis here, pandemic. Because essentially, what we're finding is we're gravitating towards some of those models without possibly even recognizing it. So, why don't we go ahead and we'll move to the next slide. So, a lot of today really is wanting to take a look and have a conversation. The first part of it is going to be having a conversation about our practice models, how we're delivering the services, what our experiences were pre and post COVID, and then what some of the learnings are. And then we'll take a look at some of the research associated that was identified in the most recent publication with Tip 63. And we'll talk a little bit about some of the models such as group and individuals and some of the research associated with group, just real briefly, and then talk a little bit about, as we're doing this via telehealth, what some of the challenges may be with group and how do we overcome some of those, because group is really considered one of the most effective treatment modalities for substance use in general. Now, when we come to providing MAT services, we ask ourselves a variety of other questions also. So that being said, I thought what we could do is have a dialogue, which was the intention of most of this, of the didactic, and it'll probably just move through as well in terms of the Q&A as part of our dialogue here. So if we can just get a little bit of feedback to say, what were some of the challenges in delivering in general, and we've talked about some of this, behavioral health substance use treatment services pre-COVID, okay? So what were we seeing before? And then what are some of the challenges that we're seeing after? And then what are some of the similarities and differences? And there's a variety of factors, but the delivery method has been the most notable factor in terms of how we're providing services. Much of it can indeed be telehealth. Some of it is still in person, but at much more limited possible frequency, longer duration of scripts, all those kinds of things. So if we can look at some of the challenges prior that we were experiencing and working through, some of the challenges that we're experiencing today, and again, what are some of those differences and what are some of those similarities? And then we'll have a little more dialogue from there. So I would like to open it up at this point if anybody has any reflections. And we could hit all three of these at the same time if we want. If you want to hit what were some of the challenges post, what are some of the challenges pre, post, and then what are you seeing as some of the similarities and differences as you're providing services in your current approach and modality post-COVID. So, anybody like to share a reflection as we start here? I'm seeing some. So I'll ask a more specific question, and I think this might have been there might have been some dialogue last time, and that is, what are some of you doing different today, post-COVID than occurred pre-COVID? What are some of the model changes you've done? And I know we talked some about that last month, but what are some of the model changes?
This is Ann here in Machias, and I was struggling to unmute a minute.
Oh, good. Go ahead, Ann. Go ahead. You can answer all three. Yeah.
I guess one of my issues is we listened to the 2 webinars with Dr. Mock and Elaine O'Connor, which were excellent.
Yep.
And modified treatment to provide generally 14 or 28-day prescriptions of Suboxone. And of my caseload, which is around 25, now there are now 3 or 4 people that are very casual about follow-up appointments with some no-shows, and it's hard to get them to answer the phone. So it makes me rethink, should I have, usually before this I was giving enough medicine until the day of the visit, which was a good cue to come in and see us, and wondering if I should still do that with some people. And is there really going to be a scarcity of Suboxone, and do we need to worry about the supply? Yeah.
Okay.
That's it.
Okay. So one of the delivery method changes was specifically in terms of duration of scripts, and previously that the script renewals or extensions were at the benchmark of when they had their follow-up appointments. And now it's a lot more challenging to have individuals follow up at those benchmarks, or the benchmarks are a little more fluid at this point. Maybe added to that could be an added reflection or question, and that would be, have you seen some, particularly Ann or eSport Health, or have you seen some of the, what have you seen that has been effective in the post-COVID time in the new practice model?
Oh, well, I'll answer for us. With telehealth, we are more flexible with appointments and can respond quickly to reschedule around a low tide or high tide or whatever the needs are. And at the same time, I've had probably more clients struggling with slips and have increased visit frequency for them. So even though some are missing appointments, it seems easier to be available and help them get back with us. Yeah, that's all.
Okay. And can you describe what the behavioral health counseling component, how has that changed, and how would we say that's going, and how is it integrated as part of the visits currently? Okay.
Hi, Clem. This is Tara and Debbie from St.
Hey, Tara and Debbie, thanks.
We found that doing telehealth with people and seeing the video, it's been good to see people in their home environment, and they're a little more relaxed, and they tend to share a little bit more and in a different way. So we've had some breakthroughs with people, kind of seeing them at home and with other people coming in another picture too. It kind of shows what their life is really like.
Correct. So one of the pluses in both, I'm assuming in both the MAT delivery as well as the behavioral health counseling, is that you can really see what the home environment is like. You can really get a sense of what the home experience is like for individuals. Okay. And does that, and how are you collecting that information as part of your practice? So if they're more comfortable or you're seeing things that are concerning, how are you able to use that information to support you in the clinical approaches or interventions that you might be doing?
Well, I can share, Clem, at the recovery center down in York. They made the jump late March to all phone and telehealth. And we've been watching show rates and new client access very carefully. And it's interesting. I attended a couple of groups, a few MAC groups and a few of the level 1 outpatient groups. And, you know, to just sort of hear from clients directly, what's your experience like going from, you know, sort of in-person services to phone or video? And pretty much across the board, people talked about it's really different being in my house, that it's more intimate. You can hear things that are going on potentially around. One gentleman said, you know, a big part of my ritual on Tuesday nights was the 30-minute commute to the men's group. And I found as I got my coat on and got in my car, my whole mindset changed. And it's a little harder to find that pre-group space without the commute. And that was, he sort of viewed that as, you know, that's his time. And instead saying to your 16-year-old, could you leave the living room so I can do my group, right, is a little different experience. But folks are by and large saying they feel like their needs are being met, and that the forums provide really, you know, a very similar experience in terms of divulging and talking about the kinds of things that they needed to talk about. He quickly shifted the focus questions to, it's 5:15, this is what time I drink, could we talk about that? Excellent. You know, which was very telling. And so what we're learning is our clients are there to do the work that they're there to do. And they're sometimes not struggling as much with the medium as we are, in terms of, you know, being conversational with people. So I will stop there, but wanted to share some of those recent experiences.
Yeah. Thank you so much. I think that that's really, really helpful, because have received several pieces of feedback in regards to that being able to have an experience in the home really, really allows people to be real, to be able to talk about their immediate challenges, just as you identified, Eric. And I think that we can, why don't we move to the next slide, and we'll review some of those questions as well. But I think one of the areas that's really interesting when we look at substance use counseling and group work, which has been considered much of the standard in terms of the field of substance use recovery, which relies on peers to really support each other. And the development of relationships has been very, very critical. And it really started off from some of the self-help recovery models from many, many years ago, having people come together and have a very similar shared experience about their own challenges in recovery. And so what we have done is we have used group treatment to really capitalize on the relationship that individuals have with each other, to support each other through a recovery process. And group is used significantly. So now what we have is, in this particular case with group, is that we can't draw on the strength of the relationships that we would have traditionally, that we have really developed a lot of our treatment thought process around. And so now it means that we have to shift and rethink some of that. I think, Eric, what you've just identified is though we may not have the relationship that we would like to see in a traditional group, for example, an individual has a different set of questions. What we can do, though, is to help facilitate individuals working through their own challenges in a home setting, even in a group or individual. So though the relationship may be different in terms of not being physically together, how do we utilize the strengths of those relationships that we've either had pre-COVID or that we're developing within group work currently, and utilize that to allow people to feel comfortable in their home settings to be able to talk about some of those challenges and being able to be very real with the group members at the time or individuals that are getting services at the particular time. So I think as we begin to look at what are the implications, I think groups specifically, we have utilized the backdrop of strong level of relationships with each other. And now when we're attempting to do group through a telehealth model, it has a very different flavor and approach to it. And how do we accommodate that? And I think your point is very good, Eric, is that are we more concerned about the fact that we relied on group interactions and group relationships, and that those become more of our challenges and barriers that it might be for the clients that are receiving services. So just a general reflection about the group component and our own challenges and sort of providing delivery around a telehealth model. So as you all began to roll out, and we're talking, this particular component talks a fair amount about the substance use counseling component. As you began to roll out some of the services in the initial COVID-19, what did you originally find were some of your learnings? What did you have to adjust immediately to make this thing work? Anybody have any thoughts? Like, what did you learn in the first 2-3 weeks of this, or 4 weeks, that you said, boy, I really, really need to make some different changes in the way that I'm providing the service? So any thoughts or reflections? Or I can ask the question a little differently. What have you held on today in terms of your modifications in the way you provided services for the past 6 weeks, let's say? What have you held in terms of said, okay, I started with this and today I'm doing this, and we have learned this through the process, and this is how we've modified our model over the past 6 weeks?
Hey, Clem, it's Ann again. Hi.
That's okay.
So, yeah, we've changed our approach to urine testing, of course, to make it more safe and in keeping with infection control. But we're starting to do more in-person visits now and finding, yep. I mean, I agree that it's really great a lot of times to see people in their home environments. But on the other hand, there are some clients who cannot talk freely and are very shut down. So we've had some clients who are really enthusiastic about coming back to the office, and yet there are some that do better within home and really resonate. So I'm hoping the insurances allow us to continue the telehealth permanently, because it just gives us a wider variety of options.
Yep. Yep. Yeah. Really good point. And so for some of them, in person really is the better medium for them, and they're much more comfortable. Are you finding that's true for certain population groups than others? if you had to quantify which population groups do better with electronic medium versus face-to-face, or vice versa?
Well, I have a caseload with a lot of people with anxiety. So people with agoraphobia who have always struggled are loving this. But I think people with issues of domestic violence at home are not very comfortable talking on the Zoom. And I think it's could even sometimes, I worry about safety and what I'm saying and what they're saying and how it's all going to go. Yeah.
Okay. Anything around age groups, populations, younger, older?
Not so much on our end. I don't know about others. It's kind of been unpredictable that way.
Okay. Okay.
Hi, Clem, it's Abby.
Hi, Abby.
I just want to share that while it's not providing MAT services through our work at the Community Care and Collaborative, what we've seen as one of the biggest barriers is as far as equity and just that digital literacy. And we've made offers to meet community members in the community to provide some walkthroughs with accessing Zoom on their telephone, those sort of things, because it has been a significant barrier to accessing some of the support groups that we offer. So much so that we've had community members that may traditionally have attended the in-person gatherings not attend. And so we really saw that as a barrier. We also recognize that privacy was a barrier, and so we extended the offer of headphones to those community members as well. So when intimate information were shared by other members, it wouldn't be overheard, but to Anne's sharing, they may not feel comfortable sharing in their home with others in the home. But those were some of the pieces we saw as a barrier and some of the steps that we've taken to try to resolve some of those issues, but they continue to be a barrier.
Okay. That's a really good point. Telehealth literacy, or comfort level in using a different medium, and how do we support people and through that practice. You can probably reflect to this, Abby. I've noticed certainly in as part of utilizing this platform for drug court that younger people are more comfortable. They're more acclimated. Older people struggle a little more. When I say older people, just that they've been a certain population has been raised in a more electronic era, and has a much higher greater comfort. So their own sort of literacy to that is very indicative of what you just identified.
Clem, I have a question for you. This is Caroline. Have you received, or anybody on this session, has anybody received any feedback from clients about the overall feel of whether it's one-on-one counseling or the group counseling? Do clients say, this just doesn't feel like I'm getting that same sort of, I guess, therapeutic environment that I once was? I'm just curious what clients are saying.
Right. I know Lisa has shared various comments over time from the DTC. I'm not seeing her on. I see Linda's on, in terms of what some of those experiences. But anybody have any thoughts about what clients are reporting, utilizing the telehealth models, especially now versus earlier?
Yeah, this is Linda. I'm having trouble with the video, but can you? As far as patients, I've had sort of mixed, but several of them have told me that it's just not the same, that they really miss the one-on-one. And one of them that was doing very well anyway had asked to go to come less frequently, to be because he found it actually he didn't really like the phone.
I'll add, this is Elaine. I mean, my patients largely have not liked it terrifically well. We don't do any kind of video conferencing. That has not been approved at Maine General, so it's just over the phone, which has been hard for patients. I think people find it more convenient. I mean, I think people who are home with their 3 kids or 4 kids because somebody's working, and you know, that's been nice that they don't have to drive. But at the same time, you're also sort of calling people, you know, and I always start with, can you talk to me right now? And, you know, and then oftentimes you're like, oh my God, I'm at work. Can you call me back in 10 minutes? Because like, I can't talk here. And it just gets very, I really worry about who's listening and am I on speaker? And, you know, can somebody overhear? And that part really feels not great. And we've had patients demand to come in because they don't like working over the phone. The challenge for our patients is they have to wear masks when they come in, and that is for our patients with anxiety, or it's been really difficult for them to sit talking to me with a mask on. So I've actually let them take it off some. I probably shouldn't report that, but I've let them take it off some just because it's been so triggering for them. And then we make sure we're 6 feet apart, and I have a mask on, so I think we're okay. But it's just been really hard with that feeling of it right up close to their face, and they feel like they can't breathe, and it really hasn't made for a very therapeutic visit.
Thanks, Elaine. That's actually very, very helpful in terms of people's experience, especially when they're used to having the face-to-face contacts. Are you getting much feedback about how much that people appreciate the convenience of not having to travel, come in, that this is really more supportive to their lives and their schedules, and that they appreciate or value this type of service that we're providing? Some of them do come in, but I mean, are we getting much feedback in terms of our patients?
I feel like the super stable people, like there's a small subset of people that I feel really good about with doing this. I mean, I feel like the super stable, like that probably I don't need to see once a month anyway, but that's been our policy. Like, I feel like they're doing fine, but by and large, I'm really more worried than feel more confident. I mean, and I feel like we've had to step in and become the support structure that has otherwise been present, but is no longer there. I mean, I think people feel like they're just sort of out in this abyss and you know, really struggling because almost no one's, you know, I have people that are actively relapsing that if their probation officer was checking in with them, they would not be actively relapsing because that risk of going to jail is a huge deal. The other part is like our public transportation has been effectively decimated by this. I mean, we cannot get people to get here with our public transportation because they can't get drivers to drive people. So the whole system to some extent is really just not working right now. I mean, maybe I would feel differently if the video conferencing was available to me, but like I don't feel like this is helping very many people, at least in my experience.
Correct. This is actually really good observations, because a lot of the discussions we've been having is how organizations have been able to adapt and really continue to provide the services. And I think a really interesting reflection is that there's not the infrastructure to support individuals that are available. So regardless of whether we're using a telehealth model or not, all of the other infrastructure isn't there. As well, even more significantly, is that we don't have the same kind of access anymore. So basically, if we utilize telehealth models in a more functioning environment, we might see a better, different outcome. But what we have are individuals that are struggling, stressed, infrastructure is compromised, people are alone potentially. So it makes reviewing the models that we're utilizing tainted, in the sense that there are many, many other factors and variables in it currently.
Well, and the $1,200 stimulus check has not been good for people who have an active ongoing substance use disorder.
Right.
I mean, that has just not been helpful for them.
Right. Okay. We'll move, because I realize that we're getting closer to the end of the didactic piece. We'll have a question and answer. So if we can move to the next slide. I think I've covered most of these, Annie. How many of you are providing group and individual? How many of you are providing group services? I know the DTC is. Anybody else? Group behavioral health counseling or MAT? Okay.
Is there a slide you want me to go to, or?
Yeah, no, you're fine. You did good. You did good.
Okay.
I was picking up the group. I was trying to get a sense of the ratio between group and individual. You can move to the next slide. Yep. We've covered a lot of the learnings, or attempted to cover a lot of the learnings. Some of it was what we would incorporate going into the future, and what might that look like. I'll ask a general question. Do we feel like we're doing less behavioral health counseling now than we did pre-COVID? The answer might be pretty obvious. Have we found in some of them that we've abandoned that because it's too difficult to be able to manage? So do we feel like we're able to get, we're actively able to provide some level of behavioral health counseling during this time frame?
I'm basically just using the same format that I had been using, in group. It just comes out differently.
And we say it comes out differently. Can just
well, I've had to be a little bit more creative in how I do things, because when people are there in person, they might have a piece of paper, on a clipboard and answer questions that are on there by writing them down. In the present format, I have to kind of do it like this: put something on the screen and then kind of talk about it. Or I'll put something on the screen and then say, take 5 minutes to formulate your answers to these questions. But it is really hard, because a lot of times people are on their phones and they can't see what's on the screen, and or they're in the car. So just have to be a little bit more creative about how the things that I present.
So it sounds like you need to prompt more with materials, do a little bit more didactic. Go ahead, sorry.
Yeah. And even like, people don't realize that they can use their fingers to expand the screen to see better.
Right.
And so that kind of thing.
Okay. And it sounds like their engagement is a little different in terms of that there might be multitasking more than if they were sitting in a group, and that they're preoccupied with other things such as driving or getting other things ready here. Okay.
Yeah, and I sort of have to, the ground rules have changed a little bit also, and then I have to tell them to please park and not be driving. And this is still therapy, and it's not just a way to kill an hour and a half.
Correct. Okay. All right. Let's move to the next slide, Annie. I think we've covered some of these. So what are some of the changes and some of the changes noted in the effectiveness? We've had some discussions and we've talked about group effectiveness. We'll just cover, because I know we just have a few more moments left. We'll just cover, we can go to the next slide. We'll just cover, what I did here is, and I won't go through all this, is I was taking a look at the SAMHSA Tip 63, which many of you are familiar, and it just came out this month. So it just came out recently, the updated May 2020 version. And it has some very interesting reflections in there. For those of you who have talked to Lisa Letourneau over time, she talks about that we wouldn't hold behavioral health counseling as a requirement if, I should say withhold providing buprenorphine for individuals who are unable to attend behavioral health counseling. they basically affirm that very specifically in terms of that we want to make sure that individuals can get access to MAT, and that if there are challenges in engaging individuals in the behavioral health counseling component, that we really, really have to take that into account, but that we wouldn't withhold MAT. And it sounds like there's been an incredible response to try to accommodate that. Though some programs do specifically require individuals to attend behavioral health counseling component, that we really, really have to work at integrating that. So those components were very, very clear. And I just referenced, and you can take a look at it, some of the recommendations. And this is specifically recommendations versus requiring counseling. And talk some about that. We can go to the next slide. Annie. They also brought some information about how we've traditionally used a more confrontation expert model, and that there's research that really shows that that is not as effective. And so we've utilized that, but we've also made mega changes over time in terms of how we can utilize a more MI approach to really engage clients. So some of this you probably have seen, but there's some research that supports that as well. And we'll go to the next slide. This one is really interesting, that some of the clinical trials have really not shown a difference in certain groups in the outcomes of utilizing buprenorphine with medication management between clients or participants who get adjunctive counseling and those who don't. So, and they also, I added some of the information there. They also talked about well-structured med management programs. But essentially that there is a significant benefit, and we are all very familiar with it in terms of utilizing medication management, in terms of prescribing, and that we continue to do so. I think a lot of the information that's coming out, and many of you are aware, when we talk about counseling versus med management versus both interventions, that it's pretty clear that both interventions are very critical and very supportive, and certain populations do respond much better than others. Some of the research indicating that for some population groups, there's not a huge difference, specifically though when they're referencing well-structured med management programs and practices. So we want to make sure to keep a balance between the two. If we're having difficulty providing the behavioral health counseling, and many of us clearly come from a behavioral health counseling background and recognize the importance of it, we need to also recognize not just the balance, but that if individuals are not able to at a particular time, how do we continue to engage them in continuing to provide Suboxone while continuing to provide a level of support to engage in treatment services and the counseling services. Anybody have any reflections about that? Again, this is part of some of the data that we have seen before. Anybody have any reflections of, thank you, Annie. Anybody have any reflections or thoughts about that in general?
Can you hear me? It's Jen McConnell.
Hi, Jen.
Hey, so I'm having a terrible time with technology today, so I'm back on my iPhone. But I feel privileged because I work with groups where everything is in a group setting, and so I've seen a lot of change over this last several months. But I also have a really nice, stable private practice group where I, led in a very, very small few at a time, so I don't have a lot of high-risk folks in my private practice. I have a few, but it keeps it manageable for me. And it's interesting to, I have quite a few really stable, and I feel like I have such a great connection with them that a once a month really is their counseling.
Right.
But they've been on this for a long time, and they're very well known to me. whereas maybe the ones that I'm just sort of bringing in for a variety of reasons, they've come from somewhere, they live in this area and are just getting released from jail, etc. And I may push the counseling a little harder.
Correct.
So I feel like I have a nice mix. And just, I couldn't chime in earlier when we were talking about some of the group stuff, but watching groups go from all these inpatient to very quickly all Zoom calls. It is so nice when you can see somebody at least on Zoom, and I think the ones where we can't see them and we only see a name come up, that worries me more. And so I think I like those studies that show there's really no significant difference if people get behavioral health counseling or not. We all know people that really benefit from it. And we also really know people that would benefit from a once a month connection with an MAT prescriber who is skilled at sort of checking in with them once a month. But then there's all those people in between. So I wish we had more flexibility for people, but I do think the system is moving in a direction where there's more options for people.
Mm-hmm. Thank you. And an excellent reflection. We'll wrap up. And an excellent reflection in terms of, and some of the research supports this, if there's a good engagement with the medication management provider, and you just articulated this, then that can go a long way. Sometimes individuals have a hard time engaging in two services, especially as you've identified high needs individuals struggling with relapses, working through some significant challenges, really benefit a great deal from behavioral health counseling, and the need to really highly integrate that in a way that people could feel that and perceive that as supportive as possible. Okay. I want to thank you all. I know that some of this we have reviewed in the past, but trying to look at some of the learnings that we've experienced and how do we translate that going forward into our practices, recognizing COVID-19 is a bit different. And then how do we creatively look at the behavioral health counseling approaches, what it is that we're utilizing, be it group, individual, some of the techniques that we've applied during COVID-19, and how can we be reflective in terms of how we apply that going forward. The more we take note of that, I think our lives, as we've all heard, will probably change significantly, and it'll tax us to utilize different mechanisms to engage people in treatment. It has forced the envelope a bit to really move us to utilizing models that are creative and client focused and client friendly. With that comes some compromises and some challenges that make it more difficult for us to be able to achieve some of the work that we're looking to do. So I want to thank everybody for the conversation today, and appreciate the engagement and all the work that you're all doing during this really difficult time. So